Welcome to the debate. Today, we're diving deep into a health challenge that impacts millions, particularly our aging population, chronic venous insufficiency, or CVI. It's a progressive vascular condition that really takes a toll on quality of life, especially for older adults right here in the US. Getting its management right for this group is, well, it's absolutely crucial if we're going to help them truly master this condition.
Exactly. It's a major issue.
So our central question today revolves around this very point. Given the current evidence, what is the most critically supported primary approach to managing chronic venous insufficiency in older patients in the US? Should we be relying more on emerging pharmacological interventions, or should the emphasis remain on established, conservative, and interventional therapies? I'll be making the case for the promising benefits of these newer pharmacological interventions.
And I'll be arguing for the foundational role and, frankly, the proven efficacy of established conservative and interventional therapies. Both of our perspectives, it's important to note, are drawn directly from recent systematic reviews and comprehensive clinical guidelines.
Okay, so to start, I'd like to propose that emerging pharmacological interventions offer significant and, importantly, measurable benefits in CVI management, especially when it comes to symptom relief, which, for many older adults is their most immediate and pressing concern. A key systematic review and meta-analysis, the one looking at emerging pharmacological interventions, highlighted some truly compelling findings. For instance, drugs like hydroxyethylruticide and pycnogenol, they demonstrated statistically significant improvements in critical areas. Things like pain reduction and also a measure called resting flux, which indicates better microvascular blood flow essentially, how well blood is moving through the smallest vessels in the affected limb. Now, to put some numbers behind this, for pain reduction, hydroxyethylruticide showed a mean difference of 38 points. Now, what does a mean difference of 38 actually mean for a patient? Well, it signifies a measurable, and I'd argue, clinically meaningful decrease in daily discomfort. That could allow someone to walk farther, maybe sleep better, or simply engage more comfortably in their daily activities. For resting flux improvement, pycnogenol showed a mean difference of 25.30. Again, this isn't just a number, it points to enhanced microcirculation, which is fundamental for tissue health and healing, directly impacting how CVI symptoms progress. And these improvements were statistically significant, meaning they were unlikely due to chance. The 95% confidence interval, the CI, indicated that 95% of the time, the true effect would fall within a specific, positive range of benefit. So these findings suggest these drugs aren't just minor players, they are promising alternatives. They offer a less invasive and potentially more accessible approach for many older patients, especially when we consider their noted superiority over older, more standard options like Dosmin and Hesperidin in these specific areas. Now, the review does acknowledge that improvements in edema and quality of life were less consistent for these specific drugs, but for many patients, alleviating debilitating pain is a critical, often life-changing step towards improving their daily lives and overall well-being, really paving the way for mastering their condition.
Okay. While I certainly agree that pharmacological options, have a role to play, my perspective, which is strongly supported by current evidence, is that the primary focus for comprehensive and long-term CVI management, especially for older adults in the US, it really must remain on established, conservative, and a broad spectrum of interventional therapies. Even the emerging pharmacological interventions review, the one you just cited, is quite clear about its own limitations. It points directly to high heterogeneity, small sample sizes, and methodological inconsistencies. And let's just break that down for a moment. High heterogeneity means there was a great deal of variability in the results across different studies sometimes. As the review notes, up to 100%. That indicates the effects of these drugs just weren't consistent from one study to another. This kind of variability combines with small sample sizes and differences in study design or methodological inconsistencies, well, they fundamentally hinder the development of universally applicable guidelines. And these aren't just academic footnotes. They highlight a crucial weakness in our ability to generalize these findings to the diverse real-world population of older adults we serve. Now, in sharp contrast, you look at the ESVS 2022 Clinical Practice Guidelines, comprehensive, widely respected, and they unequivocally assert that conservative measures remain foundational. This isn't just a suggestion. It's presented as a bedrock principle. They specifically recommend elastic compression therapy, whether it's stockings or bandages, which is really a cornerstone treatment. They also advocate for tailored physical activity programs, specifically to strengthen the calf muscle pump, which is vital for propelling blood back to the heart, and targeted weight loss for obese patients. Many of these recommendations carry Class I or IIA status with Level A or B evidence. And what does that mean? Class I or IIA indicates the treatment is recommended or highly recommended because the benefits significantly outweigh the risks. Level A or B evidence means these recommendations are based on high-quality, consistent data from multiple randomized controlled trials or well-designed studies. That's the highest tier of scientific support we have. Furthermore, these guidelines highlight definitive recommendations for interventional treatments like endovenous thermal ablation. This is a procedure that directly treats the problematic veins to correct issues like venous reflux, when blood flows backward. It's recommended for symptomatic varicose veins, that's C2S in the CEAP classification, and for active venous leg ulcers, C6, or even to prevent recurrence after healing, C5. And these interventions are supported by robust Level A evidence, clearly demonstrating long-term efficacy and significantly improved quality of life. Crucially, they actually address the root cause rather than just masking the symptoms.
I see why you emphasize those foundational therapies, and I absolutely agree they are important. However, let me offer maybe a slightly different perspective on the robustness of the evidence for some of these pharmacological options. The meta-analysis, yes, despite the heterogeneity you mentioned, it did find statistically significant benefits for certain emerging drugs in critical areas like pain and microvascular function. We're talking specifically about hydroxyethylruticide and pycnogenol, and their demonstrable superiority over more traditional treatments like diosmin plus hesperidin in those specific areas. For example, that significant improvement in resting flux with pycnogenol I noted earlier, that's a tangible benefit for improving blood flow right down at the capillary level. And for older patients, particularly those here in the US, managing daily pain effectively without immediate recourse to, invasive procedures, that can be a primary, often immediate concern. Think about a patient who simply wants to maintain their daily walk or, play with their grandchildren without that debilitating leg pain. These medications can offer a tangible improvement in symptoms that directly impact their comfort and mobility. The statistical significance, even with heterogeneity, suggests that for many patients, there is a real measurable relief. Well, yes, a confidence interval like 95% CI minus 139.89 to 215.89 for overall pain reduction might seem wide when pooling everything. The individual drug data, especially for pain and microvascular function, showed much tighter and definitively positive results. That suggests specific benefits. These targeted improvements are incredibly valuable, offering a less daunting first step in CVI management for those who might be hesitant about or perhaps unsuitable for surgical intervention. This isn't about replacing everything else, but about adding a valuable, accessible initial approach to improving quality of life for a really significant portion of our older population.
That's a compelling argument for immediate symptom relief. And I agree, that's a critical aspect of patient care. Absolutely. However, when we consider that same meta-analysis, the substantial heterogeneity, I2 equals 100%, P0.001, across studies isn't just a minor point. It's a strong indicator of considerable variability in results. An I-squared of 100% tells us that all of the observed variance in treatment effect is due to true differences between the studies, not just random chance or sampling error. This makes generalizing findings really challenging, especially for a condition as varied as CVI, in a diverse population of older adults who often have multiple comorbidities. What works consistently in one specific trial setting or patient group might not translate directly to another. Moreover, the ESVS guidelines, they categorize venoactive drugs generally as providing benefits for symptoms and edema, sure, but often without that high-level evidence like Class 1, Level A, that we see for many interventional or compression therapies. The guidelines specifically state, and I think this is important, that significant gaps remain in evidence, particularly for certain therapies. That sentiment is echoed by the pharmacological review itself when it points to those methodological inconsistencies that hinder the development of universally applicable guidelines. For instance, let's just contrast this with compression therapy for a second. It's been proven effective in relieving symptoms and reducing venous pressure, with robust, high-level evidence for patients with C1s through C3's CEAP clinical class, meaning those with visible spider veins, reticular veins, or varicose veins, with or without symptoms. This isn't just about managing symptoms temporarily. It's about providing a consistent, evidence-based foundation that reliably improves outcomes across a broad patient spectrum because it directly addresses the underlying venous celiac issues. The strength of evidence for these established approaches just gives us far greater confidence in their universal applicability compared to some of the newer drugs where the data is still a bit mixed.
That's an interesting point about heterogeneity and let's say, the gold standard of evidence, though. I might frame it a bit differently. While heterogeneity is certainly a challenge in pooling CVI research, the consistent positive trends for particular drugs still suggest a valuable therapeutic role. We're talking about specific, measurable benefits in pain and microvascular function. These are direct improvements in a patient's daily life. And for many seniors, a less invasive pharmacological approach might just be preferable, especially when you consider the prevalence of polypharmacy, taking multiple medications already, and potential reluctance towards procedures due to age, frailty, or existing health conditions. Imagine a patient, maybe in their late 70s, already managing hypertension, diabetes, and arthritis. They simply want to get around their home more easily. Adding a complex, potentially risky surgical procedure to their already full medical plate, well, it might be out of the question. The Emerging Pharmacological Interventions Review itself emphasizes the importance of personalized and cost-effective strategies, which could certainly include these pharmacological options as a first line. They can offer that immediate relief that significantly impacts quality of life, allowing them to remain active and engaged, which we know is crucial for overall health in older age and a key part of mastering CVI. It's interesting, the ESVS guidelines, even while pushing for interventions, acknowledge that in older patients, and I quote, "rehabilitation strategies are particularly important due to the high prevalence of polypharmacy and its associated risks." This highlights the very real need for less invasive, more easily integrated options for many. These medications can provide that crucial, early improvement in daily function and comfort, which, let's be honest, is often the patient's primary goal.
Okay, but my perspective shifts slightly when we consider the fundamental pathology of CVI and, crucially, the long-term effectiveness. While immediate symptom relief is undeniably important, the ESVS guidelines strongly advocate for interventions that address the underlying pathophysiology, things like venous hypertension, reflux, or obstruction directly. These are the root causes of CVI, and interventions that target them offer far more durable and lasting results. For instance, early endovenous ablation for active venous leg ulceration, that's C6, is recommended with Class I Level B evidence specifically to accelerate ulcer healing. That's a direct impact on a major complication. Similarly, treating incompetent superficial veins after ulcers have healed, C5, is recommended to reduce the risk of ulcer recurrence, and that's with Class I Level A evidence. These are not just symptom managers. These are interventions that fundamentally alter the disease course. They provide a more permanent solution and truly enable patients to master their CVI, not just, cope with it day to day. Furthermore, that very pharmacological review we're discussing presented a meta-regression analysis, and it showed a significant negative temporal trend for these drug interventions. What does this mean? It indicates that the effectiveness of these drug-based approaches was observed to decrease over time by approximately 3.79 units per year. Now, that's a critical finding. It raises serious concerns about the sustained long-term efficacy of these pharmacological approaches compared to the more definitive and durable procedural ones that actually address the root cause of CVI. I mean, I recall a patient who initially felt great on a new medication, but after a year or two, we were essentially back to square one, and we really had to consider more definitive options at that point. This finding kind of echoes that clinical reality we sometimes see with drug-only approaches. While they might offer initial relief, the evidence suggests that they just don't provide the lasting correction or prevention of recurrence that targeted interventions do.
I hear your point about definitive interventions, and yes, the evidence for them is robust. But let's circle back to the real-world barriers for older adults. Things like access to specialized care, the recovery time needed after procedures, the potential for complications. How do we ensure these interventions are truly accessible and, frankly, appropriate for a patient population that's often dealing with multiple comorbidities? I'm not entirely convinced that focusing solely on interventions addressing underlying pathology is the primary approach for all older adults, especially when we talk about practical, patient-centered care. For many older adults, the barriers to interventional therapies can be substantial. Consider someone living in a rural area of the US where access to vascular specialists might be limited, or maybe an individual managing multiple chronic conditions like hypertension, diabetes, heart disease, which is common. Epidemiological data suggests up to 30% of CVI patients are over 65, and comorbidities like these are incredibly prevalent in this demographic. For such patients, the risks associated with procedures, coupled with potential complications, or maybe extended recovery times, well, it can make interventions a less desirable or sometimes even a medically contraindicated option. Pharmacological options, in contrast, can offer a more readily available solution, often managed by a general practitioner, to alleviate those distressing symptoms like pain and swelling. They can integrate pretty seamlessly into existing care plans, especially for those who aren't suitable for, or perhaps just aren't willing to undergo, invasive interventions. The goal, particularly for this demographic, is often about maximizing comfort and function with the least intrusive methods possible, empowering them to maintain independence and a good quality of life. These drugs offer a crucial tool in that arsenal, allowing for a personalized approach that really respects individual patient circumstances and preferences.
That's a compelling argument regarding accessibility and patient factors, and I agree those are absolutely critical considerations, no question. However, I'd argue that the ESVS guidelines actually factor in these practical considerations for older patients in a very sophisticated way already. They explicitly discuss shared decision-making and promote patient-tailored treatment approaches, specifically recognizing individual patient characteristics, comorbidities, and importantly, preferences. These aren't just buzzwords. They represent a fundamental commitment to crafting care plans that respect the patient's unique situation, including their ability and willingness to undergo procedures. And this is precisely why a holistic approach is so heavily emphasized, an approach that includes not just interventions, but also those non-pharmacological, low-risk, and highly beneficial strategies like physical activity and weight loss. For older patients where, as you noted, quoting the guidelines, rehabilitation strategies are particularly important due to the high prevalence of polypharmacy and its associated risks, these non-pharmacological methods are invaluable. For example, for obese patients with CVI, weight loss isn't just generally healthy advice, it's a Class 2A recommendation specifically for improving venous outcomes because it directly reduces venous hypertension and improves symptoms. This demonstrates a robust framework that really embraces a blend of non-pharmacological and, when appropriate, interventional strategies. It prioritizes safety and long-term well-being alongside symptom relief, recognizing that true mastery of CVI for our aging population often comes from a comprehensive approach that tackles the disease from multiple angles, not just, through a pill. We're talking about building sustainable health improvements here, not just managing symptoms temporarily.
So, in summarizing my position, I really want to reiterate the undeniable value of emerging pharmacological agents like hydroxyethylruticide and pycnogenol. They offer immediate and accessible symptom relief, especially in terms of pain and microvascular function aspects that are absolutely critical for enhancing the daily lives of older adults managing CVI here in the US. Despite existing research limitations, like the heterogeneity we discussed, the potential positive impact on quality of life without the invasiveness or potential risks of procedures makes them a vital component in a patient-centered care plan. They're particularly important, I think, for those with multiple comorbidities, where polypharmacy is a concern, or for those facing limited access to specialized interventions. These medications provide a practical, often frontline approach that can empower patients to take significant steps towards mastering their CVI, improving their daily comfort and function, and crucially, maintaining their independence.
And my position remains firm. While pharmacology certainly has its place, the robust evidence from comprehensive guidelines strongly supports a primary strategy centered on foundational, conservative measures and definitively effective interventional therapies. These approaches directly address the underlying pathophysiology of CVI, offering superior long-term outcomes in things like ulcer healing, recurrence prevention, and overall disease progression. For older adults, this comprehensive, evidence-based strategy, including compression therapy, tailored physical activity, weight management, and timely targeted interventions when needed, ensures that we are not just managing symptoms, we are aiming for true mastery of chronic venous insufficiency, leading to a more profound and sustained improvement in their quality of life by tackling the root causes for lasting benefit.
Indeed. It's clear that the management of CVI, especially for older adults, is incredibly multifaceted. It often requires a blend of approaches, really tailored to the individual.
Right, and our discussion today, I think, highlighting the nuances between these emerging pharmacological interventions and the established therapies, it absolutely underscores the ongoing need for more standardized and comparative research, particularly looking at the long-term outcomes of some of these newer agents.
Absolutely. And ultimately, it emphasizes the paramount importance of individual patient assessment and truly shared decision-making in tailoring the most effective care plan for each person. We leave it to our listeners to weigh the evidence presented today, consider these diverse perspectives, and perhaps, with this deeper understanding, feel more equipped to help themselves or their loved ones in mastering this complex health challenge.